Okay, here we go. Stress testing. Unit 2, lesson 1. Let's get to it. Okay, so we're going to talk about like what is a stress test first. Here's your note packet, by the way. You should have this printed. If you have not printed your note packet, you need the note packet before we start. Correct. It says Unit 2, Lesson 1. So we have 3 lessons for this unit. This is Lesson 1. It's fairly short. This is all about stress testing. And we're going to be doing that in next class. So we're going to hook people up, and we've already done the resting EKGs, and now we're going to move to the next step and start doing going through the stress test process so that we can get tested out on that later this semester. Okay, so we'll go over what's a stress test. We'll talk about the difference between a clinical stress test and an exercise stress test. We'll also talk about any pharmacological stress tests. That is, if somebody cannot walk on the treadmill, they physically cannot are unable to walk on the treadmill, we can still do a stress test on them. We'll tell you how that works. And then we'll go through a few examples and a review. All right, let's go. Okay, so what's a stress test? First and foremost, is a stress test is a way to measure how your heart actually handles stress. Let me move my face for a minute. I know you need to write this down. So it is it's a way basically to measure how your heart handles stress. And when we stress somebody, we are usually exercising them. When we're putting our heart under stress, then we are usually exercising. So during exercise or stress to the heart, the body has these normal exercise response that happen. Okay, we're looking for that normal exercise response while they're on the treadmill. It's different as we age, obviously, that changes slightly, but for our normal, everyday, average person, might be a little bit different than what our athletes can do. So, we have some charts. I'll show you those later, but we're looking at how the body should act normally during exercise. Okay, I'm going to move my face again. All right, so the heart rate is supposed to increase while we exercise, correct? The blood vessels will vasodilate. This is a natural response to stress. So we talked about beta and alpha and all those. This is a natural response. Those blood vessels will vasodilate, okay? It's one of those fight or flight things, and it's made so that we are now able to get blood to our organs very rapidly. So we're getting oxygen and blood to our heart muscle and to our leg muscles so we can run, basically, okay? The systolic blood pressure will increase, so our heart's going to pump harder, and therefore that's going to increase the cardiac output as well. So it's going to increase how hard our heart pumps and how fast it pumps. And last but not least, it seems like it was contradictory, but it's not. If you think about it, the diastolic, because the blood vessels vasodilate, that diastolic blood pressure, the bottom number of our heart of our blood pressure, will usually decrease. And this is because we've now vasodilated those blood vessels. They're much wider and open. And since diastolic blood pressure reads the pressure inside our blood vessels when the heart's relaxing, and it's now nice and wide, it doesn't have to work as hard to get through there. So it actually lowers the diastolic blood pressure. That is a natural response. Higher systolic, lower diastolic. And then again, it's just a way for those organs to be fed oxygen a little bit faster under stress. Okay. Obviously, throughout these videos, I say this a million times. If you need to stop and write things down, if I'm going too fast, just pause. Okay, so why are we performing a stress test? There's a couple different reasons. So main reason or first reason we can think of is to absorb the normal exercise response and endurance. Obviously, we're going to see if their blood pressure is going up, their heart rate's going up, their respiratory rate's going up. We're watching for that natural exercise response. And then endurance, how long can they go, right? Certain age groups can go a little bit further. Supposedly genders can go a little bit further too. We'll talk about that too. But there's a set average or scale that happens for different ages and gender groups. And then to absorb any symptoms like fatigue, chest discomfort. If they get chest pain while they're exercising, that's not good. That usually means something's going on in the heart or the lungs. They might have dizziness. They might have dyspnea. That's just shortness of breath. So some of these might come on, obviously, if we're exercising really, really fast and really, really hard, and we're, at maximum capacity at this point, we're going all out. We're going to have some of these anyway, right? But we shouldn't have these sort of symptoms if our heart rate's only at like 110. Okay. So we're looking for these abnormal things that happen while we exercise. So these are all things that do happen while you exercise, but if they happen at abnormal rates or very quickly or not at all, or the heart rate just doesn't go up, then we have some abnormalities happening. So we're looking for all of that together. Okay, then we're also, so in the clinical setting, I am looking at the hospital, I'm looking to check for any blockages in the coronary arteries. So obviously our heart is surrounded by all those arteries that feed the heart muscle with oxygen, those big coronary arteries. If we have any blockages in those coronary arteries and we don't get blood flow to a certain area of the heart, we got a problem, right? So our stress test at the hospital can tell or lead us to believe that there could be a blockage in one of those coronary arteries, and we can tell that by any changes we might see on the EKG. Okay, there's another little piece that goes with it, and we'll learn that too. We can take some pictures of the arteries before and after. And then last, for most of you, a lot of you are going into the field of personal training or sports training or, sports medicine, that sort of thing. It is to get a baseline of exercise capacity in order to build a proper exercise program for. So if we get them on the treadmill, we get them doing the stress test, we watch their EKG changes, they're all normal, their blood pressure response is normal, but it happens really fast. So say they can only go 5 minutes on the treadmill. A goal would be to push it to like 8 or 9 minutes on the treadmill. So it's just one of those ways to build that program and make sure that they have the exercise capacity to do that and go. And it's one of those tools that you have in your bag, basically. All right. Doesn't want to change. There we go. I'm a little behind, I think. Looks like a little bit behind here. Don't know why. All right. So a treadmill stress test, which is what we're going to be doing this week, is also called the Bruce protocol. So his name was Bruce, not his first name. His last name was Bruce. He came up with this universal program. It is used worldwide, exact same program. The treadmill stress system is set up for a specific protocol for everyone, no matter what age they get on the treadmill. Okay. So the clients or indoor patients are hooked up to a 12-lead EKG monitor and a blood pressure cuff. So we get their 12 leads on, and we learned the modified position. We're going to go through the modified position to make sure that they're hooked up correctly. Remember we talked about in class, it's not real smart to hook it up to their wrists and ankles if they're going to be on a treadmill. So we're going to do a modified situation with that. Okay, so baseline pictures of the heart and blood pressure are taken in a couple different positions, and then we think about the heart axis. We talked about it can change by different positions we're in. So in our case, we're going to do one in supine, so lying down, and then we're going to do one in sitting, and then we're going to do one standing. So we're going to do 3 different positions for our blood pressure and heart EKG baselines. So we will note that on each of the EKGs. This one is supine, this one is sitting, this one is standing. Again, we might see a difference in the heart axis. It just helps us kind of gauge what it's going to look like when we're on the treadmill. So it is a preset protocol, again, on the treadmill. It starts off a bit slow. It's only at 1.7 miles per hour, but it's on an incline of 10%. So a lot of the gym ones, like a lot of the treadmills in the gym, only go to 15%. This goes to 22 or 24%. I can't remember exactly. It goes pretty high. It's a really high, really high. It's designed for the treadmill to win. It's not designed for you guys to actually finish the test, okay? Rarely do we see somebody ever finish the test, all right? So every 3 minutes, it is set to go a little bit higher and a little bit faster. We're watching that heart rate increase gradually and while we increase the exercise response. So we're watching everything go up naturally, gradually, in a safe manner. Okay, so every 3 minutes, it's set to go up just a little higher, a little faster, and we're gradually increasing that. Most of the time, it's just like a walk to a little bit faster walk to a speed walk, maybe to a jog. But by the time we're at the jog phase, it's at a really steep hill, so it's hard to do. So we're going to practice doing that in class, you'll see. And then blood pressure is taken manually during each stage, and then you record that with any symptoms throughout the test. You're going to ask the patient as well, or the client, how they're feeling, what's their perceived rate of exertion, okay? That PRE, perceived rate of exertion. There's a chart on the wall that we can use. That one goes like all the way to 20. At the hospital, we use like a 1 to 10. So it really just depends on, your site, your facility, and whatever they use. And you can say, "Hey, are you almost done? Are you going to be able to finish? Can you go another minute? Like, can you go 2 minutes? Do you think you can go higher and faster?" Just stay constantly talking with that patient. Okay, that's the basic thing. Just to make sure you're recording how they're feeling throughout the test and any symptoms they might have. Okay, so prior to starting the test, you need to calculate the heart rate max for that client or patient. And I know that you guys have probably heard this before and done it before. It is 220 minus the age. And that 220 minus the age is the heart rate max. 85% of the heart rate max becomes what we call the target heart rate, okay, for each client or patient based on age. So 220 minus your age, obviously, it's based on age, right? And you take 85% of that. So you need to calculate that first. So we know what our target heart rate is, okay? So we're going to be in what's called a non-clinical setting. So we're not going to be in the presence of a doctor or nurse practitioner when we do the stress test. Because of that, we have a strict policy that once the patient has reached their 85% of their heart rate max, the test is over. Okay, we will stop the treadmill, let them come down and do their resting, walk on the EKG, and then they do a preset cool down, and we go from there. If we're in the clinical setting at the hospital, I push them past 85%. We want to make sure that we have a safe test, and when they leave us, they're going to be safe to do exercise and push their body a little bit. But because we're being in a non-clinical setting, we're going to go to that 85%. Okay. So once we have finished our 1-minute walking cool down, we'll take a blood pressure while they do that. We will then sit them down. We'll take another blood pressure, and we're going to monitor their blood pressure and heart rate for a few minutes, up to 5 or 6 minutes, until it starts to come back down to baseline. Any symptoms that they have during that, we write down. We're writing down the EKG, not the EKG. We're writing down the blood pressure, and we're printing some EKGs for our records just to see if there's any changes on the EKG. All right, so these are the phases of Bruce protocol. Okay. So you can see that stage 1 here, they all are 3 minutes. And we start at 1.7 miles per hour at a 10% grade. High. I mean, just 1.7 is really slow. I know you guys are gonna be like, this is so slow. It's kind of like awkwardly slow, but it's on a hill. So the hill is what gets everybody, okay? Then notice after 3 minutes, we'll go to stage 2, and we're going at 2.5 miles per hour at 12% grade. And then stage 3 is 3.4 at 14. Stage 4 is 4.2 at 16. Stage 5 is 5 miles per hour at 18. So a lot of you are like, hey, I run and jog on the treadmill. I go up to 5, 5.5, 6.8. But are you at a 22% grade? Probably not. So it's much more challenging than you think it would be. But I'm excited to see how you guys try it out. It'll be fun. All right, so stress testing for exercise prescription. So this is what most of you are going to be using this for, I'm assuming, unless you go into the clinical setting like where I work. So we're determining the client or patient's functional capacities at baseline. We want their VO2 max, their anaerobic threshold. We want all that stuff at baseline. And then we're going to exercise them. So we're going to monitor progress and response of the patient once they're in the exercise program. And then we'll make adjustments to exercise plan based on both initial and ongoing results. This is nothing new to you guys. Okay, so just the treadmill stress test is just another thing to add to your baseline and your thresholds to see, how well they can work out and how well they can improve. So it's just another method of testing them to add to their exercise program and come back and retest and see how they did later. Okay, that's really all it's for. It can diagnose some things that they didn't even know they had too. So we'll learn that as we go too. It's pretty interesting what you can learn from just a treadmill stress test. All right, so for clinical interpretation, this is what I do at the hospital. Okay, so I determine the body's capacity to handle stress on the heart through exercise in a controlled environment. Obviously, there's a nurse practitioner and/or a cardiologist present while I do the test. I am running the entire test. I welcome the patient. I get them hooked up. I tell them what their expectations are for the test, take the baseline pictures, and then when the doctor and nurse practitioner gets there, they have them kind of sign the consent, and then I run with the test. The doctor's just watching. Okay, I'm doing all the tests. I'm conversing with the patient. I'm asking how they're feeling. I'm making sure they can go and keep going the way they're going, that they're not going to fall off the treadmill, all kinds of things. I've actually had to teach people how to walk on a treadmill before because they've never have. It's very interesting sometimes. But we're going to look for signs while they're up there. Any signs and symptoms of ischemia. So that looks very different on the EKG. That's your next lesson next week, is what ischemia looks like in both the client and patient reactions and on the EKG changes. So if they're having physical symptoms like chest tightness or chest pain or shortness of breath, and then in turn I see changes on the EKG, we can coincide those together and put those together and go, hey, I got two pieces that fit together. They have ischemia. Okay. And then we can determine if there's a potential blockage in any of the coronary arteries based on where it's located. I know you guys learned the different locations of the heart. Like, so 1 in AVL was lateral, 2, 3 in AVF was inferior. This comes into play heavy with this unit. Okay, so 1 in AVL are lateral, 2, 3 in AVF were inferior. 1 through 4 were anterior, and 5 and 6 were apical. So if I see ischemic changes in leads 1 in AVL, I know that they have some sort of blockage happening in the lateral region of the heart. It tells the doctor exactly where to look when they have to go in and do their cardiac cath. It's such a huge tool to help these doctors and cardiologists figure out what's going on with this patient without being too invasive. And then we're going to monitor for any stress-induced arrhythmias as well. So we might put them into an arrhythmia that they didn't know they had. Or maybe one of the symptoms they've been having is I just have these palpitations and I have chest pain with the palpitations, and they're going in and out of an arrhythmia. Because they're not hooked up to a monitor, we don't know until we actually test them out and put them on a treadmill and see what happens. Yeah. So I did a whole year clinical rotation at Nemours on stress tests on children. Yes. A lot of them were children that had heart transplants or heart surgery when they were younger. My youngest one on a treadmill was 5 years old. She was adorable. She she had little pigtails. She had heart surgery when she was younger, and she was going to school now in kindergarten, and they needed to clear her to do gym class. So we had to put her on the treadmill and make sure her heart was going to handle it. It was so adorable. But I did a stress test a couple different times on teenagers that had a cardiac arrest event. So that meant that this one kid was playing basketball, got hit in the chest, cardiac arrest. They got him back with an AED and CPR. He lived, obviously, came back, was in the hospital for a few days, and we put him on a treadmill to see if it was going to happen again. Yes, we did. That was our job. Let's see if we can get him to go into cardiac arrest, or at least get him to go into a weird arrhythmia that may have caused the cardiac arrest, so that we can kind of see what happens to the heart when it's under stress and exercise. So that's what they do. This is just a really cool way, safe way to see what happens when you put their heart under stress. All right, so treadmill stress test more. I believe this is a video. It's taking forever to come up. All right, we're going to watch this video together.
Hello, my name is Greg Puter, Manager of Cardiopulmonary Diagnostics and Cardiac and Pulmonary Rehab here at Allegiance Health, and today we're going to be talking about cardiac stress testing. And the indication for cardiac stress testing is to look at the physiologic effects of your heart. We want to look at the rate at which your heart is beating. We want to look at the response of the heart rate. We also want to look at the response that you have with blood pressures during the test. So we're physically looking at the heart physiologic action or the action of the heart and how it's working under stress. Now, the indications for the cardiac stress test are many. It can be for a cardiac evaluation for surgery. It can be for a patient who comes into our emergency department with chest pain and it's unspecified. So we have a cardiac stress test to identify whether or not there's been any type of damage to the heart. All patients who come in for cardiac stress testing, independent of the type of test that they have to have a standard 12-lead EKG electrocardiogram prep attached to them so that we can effectively monitor the rhythm of the heart. We have a number of cardiac stress tests that we perform, and a lot of it depends upon what we're looking for and the level of the patient's ability to perform a test. With our cardiac stress testing, obviously we try to get patients to perform exercise. Exercise is the best way to stimulate the heart and to get an accurate view of how the heart is responding. In many situations, a patient is not physically able to exercise, so we have to resort to using a chemical stress test, either an adenosine or a dobutamine, to simulate that activity of the heart to evaluate the function, the blood pressure, the heart rate, and the ECG changes, if any, of the cardiac stress test. We do probably anywhere from 10 to 15 cardiac stress tests a day, a variety. Today I think we're doing some, half our tests are chemical. We have many that are walking tests, and we have 3 or 4 of the echo stress tests. So we're very versed in it. It's a very safe procedure. It's something that's very diagnostic, and it's helpful for the cardiologist and your family physician to determine what your heart is doing.
That was very well said. That's exactly what I would say. Ditto. All right, so let's talk about those people. So a nuclear medicine stress test, which is a majority of the ones that I do at the hospital, are nuclear medicine stress tests. Okay, so what does that mean? That means that we have a nuclear medicine technologist that works with us. They use a radioactive tracer. It's not a dye, it's a tracer that gets injected into the patient through an IV, and it flows throughout their body. So it kind of lights them up, if you will. They become radioactive inside their body. So they now emit what's called gamma rays. So this nifty little camera over here is what picks up those gamma rays. So they're going to take a picture of the heart at rest. Once they have done that injection, they're going to take pictures of the heart at rest. Okay. And they're looking at the coronary arteries, obviously. So this is a gamma ray camera, and this is, again, you are now emitting gamma rays off of your body with this specific radioactive tracer that they've injected. Okay, so the patient would then perform the same treadmill stress test that we're going to do in class, as we explained earlier, with one difference. They will get another dose of the tracer at peak exercise. So when we get to 85% of heart rate max, so we get to that target heart rate, right? 85%. They have to walk 1 more minute after that and let that injection circulate. So what happens is when we exercise, right, those blood vessels are open wide and we inject the tracer and it starts to flow through the body, right? Once it flows through the body and our blood vessels are open, if there's a blockage somewhere around the heart, it's going to cling to it. And it makes up this little, you'll see some shadows and stuff on the heart. Okay, it's really kind of cool. You'll see where there is actual blockages from the shadows that you see in the pictures. So after the treadmill portion of the test, the client patient will have another set of pictures taken, and then they'll compare the before and after pictures to see if the blood flow stayed the same throughout the heart. This is kind of what they look like. So the nuclear medicine physician will look at the before and after pictures of the stress. So this is, if you look at this is the apex. If you're looking at the bottom of the heart, the apex at the bottom, and you're looking up through. So you're going up through the center. This is the very apex up through the center. And you can see this means that there is blood flow all the way around the heart. But once we stress them, we're missing blood flow here. Yeah. So we have a problem here. Houston, there's a problem. So that's how they can tell that there's no blood flow during stress. So they can determine if there's any narrowing or blockages in the coronary arteries that surround the heart. And by looking at the perfusion pictures, they look kind of like donuts because it's looking at literally from the apex up through the heart. It's a little round. It's round like this, and they look through it. Then they can determine if the blood is reaching all the regions of the heart. And again, if it has a round donut, we're good. If we have pieces of the donut missing, we have a blockage. Okay. Yeah, it's pretty cool. So a pharmacological stress test, this is someone who cannot walk on a treadmill. They physically are unable. That means that they have one leg, they have back injury, they have a knee injury, they're elderly, and they walk with a cane. We can't put them on a treadmill and get a good test, right? So we're going to need to do something else. So we're going to give them a medication through their IV that simulates exercise in the body. So they're going to feel like they're exercising, but they're laying still. It's a very strange feeling from what I understand. I've never had it done because I can physically walk the treadmill, but it's everyone tells me how strange it feels. Yeah. There are two different types of medications. One is a vasodilator. This is regadenoson. We call it Lexiscan's the brand name. Regadenoson is the drug name. So when we use regadenoson, that's a vasodilator. So again, vasodilation happens during exercise. So that's what we want to do, vasodilate and push that tracer in right after. And then we'll see if anything clings, right? Um, when you vasodilate, it typically drops the blood pressure and the heart rate increases because it's under stress at this point. They get a little short of breath. It's very normal. They get kind of warm and flushed like they just ran up a flight of stairs. It only lasts a couple minutes. This test takes 6 minutes total. We also use something called dobutamine, which is a medication that increases the heart rate. It's basically adrenaline. So we do the dobutamine, we would do it exactly like the treadmill. So we give a small dosage at the beginning, and every 3 minutes we increase the dosage while we watch the heart rate come up, just as if they were walking on the treadmill. There are some contraindications to using regadenoson. People that have lung issues like COPD, seizures, that it's not the best medication for them. So we'll opt to do dobutamine versus regadenoson. Dobutamine is going to get that heart rate up to target heart rate, which is where we want to be. Regadenoson won't necessarily get it to the target heart rate, but we're vasodilating and doing all the other things. So it's an easier way to do the test. Dobutamine takes forever. It actually takes longer than treadmills because it takes a long time to get their heart rate up where it needs to be, to the target. But either one, just as effective, almost as effective as of walking on the treadmill. You're just not getting that exercise capacity part of it, right? We're not seeing how far they can go, what their symptoms are when they're exercising, if they have any fatigue. So that part is missing. But as far as like taking pictures of the coronary arteries and stuff, we're still able to do that with these two tests. There's another stress test called the stress echo testing. So it's very similar to the nuclear medicine test where they have pictures before and after the stress part. Okay. I do this at the hospital too. So I run the stress machine. The nuclear medicine tech or the echo tech runs just the pictures before and after. So we work very closely together in the hospital. We have to be on the same page. We're, work on the same schedule. We work with the same patients. So this one, instead of taking pictures with a tracer, we're going to take a echocardiogram, so an ultrasound of the heart before. So ultrasounds look a little different than nuclear medicine pictures do. So ultrasounds, you can see the heart actually squeeze and contract and move blood through the heart in real time. The nuclear medicine one, it's just still pictures. So this looks a little bit different. And then when we exercise, we want to make sure that heart is actually pumping and squeezing like it's supposed to. So this is more functional than it is like physiological than it is if we have a blockage or not. Okay. So ultrasounds will be taken at rest and then again at peak exercise. So they literally go on the treadmill up to their 85%, right? Their 85% heart rate max. Once they reach that, I shut the treadmill down. They jump back on the bed very quickly while the ultrasound tech takes a ultrasound of their heart. Yeah, it sounds like a mess. It's like perfect dismount. Yeah, it's kind of a mess. It's not. We work very well together. I'm on one side and they're on the other. So they jump off and get right in position. Usually within 30 seconds, they're taking pictures, more ultrasound pictures of their heart at peak exercise. It's kind of cool to watch, actually. Mm-hmm. So a cardiologist is there again. They're there just kind of monitor what we're doing. They're going to compare the heart function at rest and at peak for any differences. Those ventricles are squeezing as hard as they're supposed to. The blood is flowing like it's supposed to. So they're looking at the physiological more so than if there's a blockage. Okay, so it looks a little bit different. Same idea. Stress part is completely the same, but the what they're looking for is a little bit different. Just two different ways to do it. And it can be done with a treadmill or with dobutamine. So remember, if they can't walk on the treadmill, I can give them that medication that simulates the treadmill, and we can get their heart rate up to target, and then still do the echo while their heart is beating super fast. Yeah, pretty cool. I'd be curious to know if any of you have had that done before or seen it done. It's pretty cool. Obviously, I feel like I'm speaking very fast, but obviously, if I am going too fast, just pause, fill it out, rewind, re-listen to me if you want to. That's if you want to. But I think you guys got the idea. All right. All right, so when we prepare the skin for this, and we did talk about this in class last week, where we have to shave any hair that's there. So I'm hoping my guys have shaved their chests so we don't have to. So we only remove the hair where the stickers are placed. You are going to wipe that skin, that area with alcohol swabs. We're wiping off any natural body oils, any sweat, any lotion that person might have put on that day. We occasionally will rough up the skin with a scratchy surface if we need to. We've kind of gotten away from that at the hospital, but some people do use it. It's like a little small piece of sandpaper on the back of the stickers. It's not always necessary, but if we have them, we'll practice doing it or we'll pretend. Yeah. So, and then you'll apply the modified 12 lead stickers. So we want to make sure that they are in a modified position. It's extreme modified. I'm going to show you again. We're going to move it way in here. Okay. We're going to move everything all in line so that everything's kind of all right here in the center. We have less movement, less artifact on our EKG. All right, so here's the sticker placement. You can see right arm, left arm. So I'm actually going to move these way in the center when we're in class. We're going to put these all the way just right above V1 and V2, actually. We're going to get them in even closer. So the more we get them off the shoulders, in case of movement here in the shoulders, we want to get away from. So we're going to move it even closer. And then these ones down here, I actually move right up, almost up in line with these. So again, if there's any extra adipose on our patient or our client, what happens when we're walking? Stuff jiggles, right? Yep, my stuff jiggles. I know it does. Where stickers are. So the less jiggling we have, jiggle wiggle of the stickers, the less artifact we'll have. So we're going to try and move this off any jiggly wiggly areas. That was a really nice way to say that. Hopefully I didn't offend anybody. All right, so this little pack is what all of our lead wires are attached to. You've seen this before. There is a little pack, a fanny pack that you kind of put around your waist, and it just kind of keeps everything in place. I have seen people kind of just drape this over the treadmill as well. I don't know if that's the best way to do it. We'll try it a couple different ways and see what works best for you guys with our equipment that we have in the lab. All right. Okay, so reasons for the stress test, reasons to end, I'm sorry. How do we know we're done, right? How do we know this person's done, that we've got the information we need, and it was a good stress test, okay? So number one, if the patient or client is having symptoms that make it too difficult to continue, they're having some heavy chest pain, they're dizzy, they're so short of breath they can't continue, we stop the treadmill, okay? If they've had any major EKG changes. So we have ST elevation, ST depression. If you see a major heart block, something called SVT, VTAC, really extreme tachycardias with symptoms especially, then we stop. So these can be life-threatening. So if we see any changes on the EKG that are life-threatening, we stop the treadmill right away. Okay. Number three would be if this patient or client can no longer keep the pace. They're like, I just can't do this anymore. I'm too tired. My legs can't keep up. My back hurts. My knee hurts. I can't keep up. We want it to be a safe test. Safety is number one. So if they're on a treadmill exercising and we're pushing them to limits where they're going to be unsafe, that's not the best thing for the client. Okay, so we stop the treadmill if we can't keep going that pace. The patient has gotten past our target heart rate, that 85%, and or the age predicted time. We'll go through that chart in class. I'm going to give that to you in class. So the patient has reached that 85%. Remember, we're not going to be in a clinical setting, so we're going to have to shut that down. And then in the clinical setting, we might push them a little bit longer. I've pushed them up to 100%, 105% before. Yeah, I know that sounds crazy, but doctor needs to get the information. So if the doctor's there and watching and we have all the crash cart equipment, just in case, why not, right? All right, so and number five would be any other drastic and or unsafe changes in the blood pressure. So we know the blood pressure is supposed to be a certain, level. If that systolic goes way high, we get it up in the 260s, 270s. We don't want to stroke this person out. So we're going to stop the treadmill. Unsafe blood pressures are not good on the treadmill. Okay. And just the opposite, if their blood pressure bottoms out, we're increasing their blood pressure up to 140s, 150s, 160s. Then they start to feel dizzy. We take their blood pressure at the highest peak and it's down in the 90s again, stop. Okay. If we have a major change in blood pressure either way, we're going to stop the treadmill. Again, it's what's most safe for that patient. All right, so contraindications. So this is stuff that you would need to refrain from or not mix with the stress test that we're doing. Okay, so we don't want any caffeine. Okay, we want no caffeine at least 12 hours prior to the test. And that's because it naturally vasoconstricts. It's working against what we want to happen. We want to vasodilate. So no caffeine should be taken 12 hours prior to the test. That includes coffee, tea, even decaf, and chocolate has caffeine. Anything with caffeine in it, period. Beta blockers. So beta blockers are that prescription medication that keep your heart rate down. Obviously, if we take a beta blocker just before we exercise and we're trying to get our heart rate to a target heart rate, we can't, 9 times out of 10, can't get there because the beta blocker is keeping the heart rate down below in a safe range. Okay, it's totally working against us. It's funny, it's not fair to the patients because they're working really hard to get it up and they just cannot get their heart rate up. It's just terrible. It's torture. And then we typically don't get it up as high as they need to get the heart rate up as high as it needs to be. And we have to stop the test anyway and do a pharmacological. So no beta blockers within the last 12 hours. And then a troponin level. So a troponin level is a blood test. We take troponins from blood, and it is a natural enzyme in our body that if you were to take mine, it's probably 0. Walking around, we don't have troponins in our blood. If you've had some sort of damage to your heart attack, blow to the chest, any major damage to your heart or chest, then your troponin levels will increase. It's like a cry of help. Your heart cries out for help with this troponin. It's a way to diagnose, to know that something has happened to the heart. If they have high troponins, it typically means that they've already had some sort of stressful event to their heart. We're not going to stress them more. So we need to make sure their troponins are negative times 2 in the last 24 hours. So we'll take their troponin levels. Say they arrived at the emergency department with chest pain. They were mowing their lawn. I had chest pain. I didn't feel good. So I came to get checked out. We take their troponins and it's negative, the first one. Awesome. The doctors say, you can probably benefit from having a stress test. So let's do a stress test as long as the next troponins come back negative. We do a second troponin 6 hours later, it comes back negative, on for a stress test the next day. Okay. Now, if their troponins are negative first and then they start to rise, then we're worried. We're not going to put them under stress. We're going to try a different test. Typically, it's a CVA, which is it's a CAT scan of your heart arteries, or a cardiac cath. If the troponins are high enough, they think that there might be a blockage, they'll go right to a cardiac cath. Okay, so those are contraindications reasons we will not run the stress test. All right, so what do we do with these results? So exercise test, stress test for prescription. So this is, again, your sports medicine people, your personal trainers. But it can help you establish a baseline exercise capacity, and then you can set goals kind of based on the results that you do. And then after you've been putting them through your program and some of your other tests and stuff, then you can redo the stress test to see how they did and how they've improved. So for clinical diagnostics, we are looking to see if there's proper blood flow through the coronary arteries. I don't know why it's such a tongue twister for me. Proper blood flow through the coronary arteries that surround the heart. Okay. And if we don't see proper blood flow, then we're going to do some other type of intervention to see if we need to fix the blockages with stents or even bypass surgery. Okay, so It's to clinically diagnose whether their heart has any blockages in those coronary arteries. And then if it's unsafe to be that way. And then if you have positive stress tests, so positive in medicine is bad. Okay, so I have positive for tumors. That means you have tumors. Okay, positive for diabetes. That means I'm diabetic. So positive test results are bad. We want negative test results. Okay, so so if we have a positive stress test, that means there were some indications of blockages in the coronary arteries, and you'll probably need some further intervention. Okay. Just know that positive is bad in medicine. Yeah. And that's it for today. I think we did great. I will see you in class. Obviously, rewind if you need to. Send me out a message if you have any questions, and I'll see you Monday.